Hi, I'm Peter O'Kane. I'm a consultant at the Royal Bournemouth Hospital in Dorset in the UK.
I'm Jahangir Din. I'm a consultant interventional cardiologist here at the Royal Bournemouth Hospital, specialising in complex PCI.
This is a 68-year-old gentleman with exertional angina who's had symptoms for about 6 months. He's had a previous stent to the LAD, and on a recent angiogram, the LAD stent's patent. There's severe disease in the circumflex, but I think the culprit lesion here is the right coronary artery that is subtotally occluded.
What we're planning to do here is a biradial approach, setting up to treat the CTO.
We found that with a microcatheter advanced and a workhorse wire, there was no way it was going to go through the occlusion. Switched out to the fibre TA, and this would only get to the very distal cap and it wouldn't penetrate beyond. Rather than forcing this through and perhaps causing subintimal dissection, we have switched to a guy at 2, and this successfully traversed the lesion.
We're using laser atherectomy now, having crossed the lesion, to modify the fibre calcified plaque, and we're delivering this with saline injection in order to minimize the energy.
It's always worth starting a few millimeters ahead of the area of interest, because what the laser emits is an acoustic wave which propagates ahead of the laser light, and that is also a way of debulking the lesion. The best way of managing this, if you're new to laser, is that the second operator really decides when I should lase. So Jahangir will tell me when to start and when to stop based on his injection.
Yeah. Okay, ready?
Brilliant. So I'm starting quite proximal here just to make sure that we're all working. And my movement antegrade is really short. And we get 10 seconds of lasing before the machine automatically cuts out. And during that time, we're delivering saline constant energy.
So we've got some very useful OCT images, which is giving us some information about how the laser has disrupted the vessel, the amount of calcium there, which is not significant, and it also gives us useful information about the vessel size and length of stenting required.
So we discovered that there was some fibrotic tissue proximal to the occlusion. We've used the cutting balloon to predilate that, again with non-compliant balloon 3-5mm across the whole length of the segment, and now we're ready for stenting. So
having properly prepared the vessel, it's been very straightforward to deploy 2 drug-eluting stents from the distal vessel back to the proximal, and we've confirmed an excellent angiographic result as well as an excellent OCT result.
So after post-dilatation, you can see the OCT shows very good expansion of the stents, with expansion almost up to 90% across the whole length. We're happy with this. No need to take any further pictures or waste contrast, but we've got a good result in the right coronary artery.